Hi, I'm Al Varelli, one half of the teaching team of Ferry Tomanchik and myself. We have developed this program for two purposes. One is to explain and teach REACOM and EMDR via the PowerPoint presentation so that you might see and hear the information we have to offer. Secondarily, we are producing a webinar for later involvement with yourselves so that we can have an interactive and live instructional procedure. It's worth noting historically that there are many practitioners who employ EMDR, though perhaps in a slightly different manner than I will present here. Much fewer practitioners know of REACOM even in rudimentary fashion. And Ferry will be making that something you will be able to understand quite fully before the end of this presentation. One of us, Al Varelli, has combined these programs in psychotherapy with patients having a variety of issues. This combined therapy approach also has examples in a book called The Match, M-A-T-C-H, which required about 10.5 years of my time to publish. We suggest that you consider purchasing this book before the webinar because it will make that experience much fuller. As you view and listen to this presentation, consider how you might adapt and adopt this program, then save these questions and comments for the webinar. In this slide, how REACOM works by Ferry and how EMDR works by myself, Ferry's portion indicates the interrelationship between psychiatric disorders and neurocognitive dysfunction, and the chart that he will use and the explanations he will provide try to tease out the relationship between both dimensions. REACOM is able to accomplish this by the screening and therapy of cognitive deficits with REACOM. So it identifies both those areas and provides the resolution for them. By adding EMDR in my own work, I employ it so that it deals specifically with trauma that might even be interfering with a patient's effective participation in the REACOM program because of the nature of the trauma involved. There are also actual patients' resolutions in this program that will make this clearer in a more cognitive and concrete way.
Hello everyone and welcome to today's session. Thank you, Al, for introducing our presentation. I'm Ferry Tomáček, REACOM clinical consultant with Hasomed, Germany, and for Pearson Assessments, US. It's a great pleasure for me to have the opportunity to do this presentation with you, Al. It is a great enrichment to work with someone who has over 50 years of experience in the field of psychotherapy. REACOM's computer-aided cognitive remediation therapy uses repeated exercises and strategies to strengthen different cognitive skills. This form of brain training can be used with counseling to help improve cognitive processes. If these impaired skills are ignored, a person will have trouble getting through a normal day. This difficulty could cause more distress in addition to the symptoms of a mental health disorder. Cognitive remediation therapy is helpful when combined with typical treatment for several mental health disorders. This improvement promotes better social interactions, daily functioning, and overall quality of life. REACOM has been developed by well-known experts and therapists in Germany and provides more than 30 years of experience. This sophisticated system has been used and refined since the late 1980s in German-speaking countries and is used in the USA and around the world. Numerous studies have shown the efficacy and feasibility proven by approximately 70 scientific studies. REACOM was originally developed for use in the treatment of cognitive impairments resulting from acquired brain injury, such as TBI or stroke. As a result of more recent scientific findings, the system also makes an important contribution to improving cognition in people with psychiatric disorders. REACOM helps to improve specific aspects of attention, perception, working memory, language, and executive functions. There is an increasing awareness of the seriousness of cognitive dysfunction in psychiatric disorders and the need to improve cognition. Cognitive deficits are a driver of functional impairment with impacts across the spectrum of major psychiatric disorders. Cognitive deficits in psychiatric disorders ranging from decreased attention and working memory to disrupted social cognition and language. Computer-aided cognitive remediation therapy was found to improve and correct cognitive performance and real-life functioning. Psychiatric disorders are associated with complex and disease-specific patterns of cognitive impairment. Disruption of cognition is provoked and countered by various interacting genetic, epigenetic, developmental, and environmental factors. Certain cognitive impairments can be improved, rectified, or compensated, so treatment is crucial. A brief overview of the main characteristics of cognitive impairment in psychiatric disorders are shown in this table. Multiple domains are usually affected, inclusive attention, vigilance, information processing speed, working memory, episodic, semantic, verbal and visual memory, executive functions, social cognition, language, fear extinction, and more rarely procedural memory. Depending on the specific psychiatric disorder, cognitive deficits ranging from consistently present but not pronounced, over a common marked characteristic up to a core severe universal characteristic of the disorder. REACOM's cognitive remediation therapy can be beneficial to people with a wide range of mental health conditions, for example in schizophrenia. Widespread cognitive decline is one of the core features of schizophrenia. REACOM improves the skills needed for daily living. Cognitive performances concerning attention, vigilance, verbal working memory, verbal learning memory, plus reasoning and problem solving improve significantly. Due to the attention deficit hyperactivity disorder, cognitive remediation has shown to be useful for improving working memory. Major depressive disorder is the most prevalent psychiatric disorder with high relapse rates. Following usual treatment, mood may improve, but neurocognitive difficulties often persist, preventing full return to normal social function. These deficits worsen with repeated depressive episodes and are a significant predictor of relapse. Computerized cognitive remediation improves the cognitive functioning needed to respond well to depression treatment in both acutely depressed and remitted individuals. According to obsessive-compulsive disorder, OCD, cognitive remediation therapy restores cognitive functioning to prevent OCD symptoms from getting worse. Cognitive impairments affects also a significant amount of people with substance use disorders. According to one study, nearly 44% of people in therapy experience some amount of cognitive decline. Because cognitive decline is so common in people with mental health and substance use disorders, REACOM's cognitive remediation therapy offers a number of benefits in treatment, including reduced treatment dropout rates and reduced symptoms of depression. The emotional experience of psychological trauma can have long-term cognitive effects. The hallmark symptoms of PTSD involve alterations to cognitive processes such as memory, impaired ability to learn new things, attention, planning, and problem solving. The functions of the amygdala, hippocampus, and prefrontal cortex that are affected by trauma can be reversed. The brain is ever-changing and recovery is possible. Overcoming emotional trauma requires effort. But there are multiple routes, for example by combining EMDR and REACOM. Before I present you the possibilities of treatment with REACOM in more detail, I would like to emphasize the following. Improving cognitive performance in psychiatric disorders is in itself of limited benefit. A meta-analysis by McGurk et al. 2007 reported that studies that included adjunctive psychiatric rehabilitation had significantly better outcomes compared with cognitive remediation alone. The use of REACOM can be very beneficial as long as the psychologist or the therapist provides the cognitive reorganization strategies that are suitable for each person and actively encourages patient reflection so that the skills learned are transferred to everyday life. REACOM has 7 neurocognitive screenings on board. All screening modules deliver normative data in order to compare the patient's results with data of healthy persons of same age and gender. The screenings indicate the deviation from the norm value. Each screening has its own specific minimum duration corresponding to the respective test goal. The screenings last between 4 to 15 minutes on average. The screenings are supposed to assist the therapist to find the right therapy modules. They can detect which cognitive deficit the patient may have and which degree of severity can be found. As a result, the system recommends therapy modules most suitable for treating the client's specific cognitive deficits. 4 of the 7 screenings are available to examine the intensity and selectivity dimensions of attention. 2 of the 7 screenings are available to measure the memory capacity. The working memory screening measures the visual spatial memory span and certain aspects of working memory. The next one is the screening memory for words. This screening measures the verbal learning ability. Finally, a screening to examine logical reasoning. Attention training is based on the premise that attentional abilities can be improved by activating particular aspects of attention through intensive, repetitive exercises. The repeated stimulation of attentional systems via graded attention exercises facilitates changes in attentional functioning. REACOM's attention battery is designed to isolate and discretely target the subdomains of attention with training exercises. Attention is a multidimensional cognitive function, and REACOM enables with 3 modules to train and enhance the ability to stay alert, the alertness, and the abilities to maintain focus and level of attention called vigilance and sustained attention. These abilities are responsible how the brain is able to provide and keep attention. REACOM's attention battery includes 5 graded, structured exercises to improve cognitive deficits in focused attention, selective attention, and divided attention. They are characterized by filtering processes, the selectivity. Focused attention is the ability to actively focus on one thing without being distracted with other stimuli, and selective attention allows focusing on a specific stimulus while ignoring other competing or distracting stimuli. Divided attention, as the most complex variant of selectivity, refers to the ability to respond to two or more events or stimuli simultaneously. Alternating attention, the ability to change quickly and flexibly the focus of attention and switch between different events or tasks, can be trained with at least 3 to 4 modules. Visual spatial attention is essential for visual perception. REACOM offers a number of comprehensive exercises that range from visual spatial perception to visual constructive skills. Spatial attention allows to grant priority in processing and selectively process information at a given location. REACOM reinforces, strengthens, or restores impaired attention skills. Proven principles of neuroplasticity are the foundation and a driver of REACOM's effectiveness in attention deficits remediation. Training starts at a basic level and moves on to higher level attention skills. As valid for all attention functions, repetition and sufficient intensity of training is critical for re-establishing of automated attention skills. The screenshots show the modules available to improve attention activation and maintenance, focus, selectivity, processing speed and inhibition, spatial attention, spatial perception and spatial performance, and multitasking, inclusive processing speed. Deficits in memory functioning are very common in individuals with psychiatric diseases. The 7 memory trainings with REACOM assist the therapist to reinforce learning strategies and compensation techniques. We store all kinds of information in our memory. We also remember things in different ways and for different lengths of time. Information encoding, storage, or retrieval can be impaired. For affected patients, memory deficits often have serious consequences and significant impact. The interactions between attention and memory play a crucial role in information processing. Attention and memory cannot operate without each other. Attention is a complex, necessary prerequisite to memory. If an individual is unable to pay attention, new information will be not processed, they will not get in or be encoded, and the individual will be unable to remember this information later. All attention subdomains are involved, from simple alertness up to higher level attention processes as sustained attention, working memory, and divided attention. Knowing about this interaction enables a better classification of patients' self-report. Patients may report about memory problems with priority. In many cases, they are less aware about their attentional impairments because the experience of not remembering things may cause more salient functional impairment. So in many cases, specific attention trainings have to be proceeded at first. The first therapy module you see here aims to improve the working memory domain. Working memory is characterized by mechanisms and processes that hold information currently most needed for an ongoing cognitive task available for processing. Working memory is a critical and limiting factor for cognitive control and executive functions. The second one, verbal memory, aims to improve short-term plus optionally long-term memory of verbal information. 74 articles from a newspaper in different lengths and complexity are presented. The task is to memorize and recall as many details of the story as possible: names, numbers, events, objects. Afterwards, they must be reproduced by multiple choice answers or as a free recall. The memory strategy training is available for the acquisition of learning strategies in regard to verbal and non-verbal memory disorders. The used association technique is the method of Loki. A body route is provided as a learning strategy. In the acquisition phase, the client has to put the terms on different positions of the body. In the recall phase, the client follows the path once again and recalls the memorized terms. The physiognomic memory trains the recognition of faces. In higher levels of difficulty, faces plus name plus job or plus a phone number. By using the module topological memory, a variable number of cards with concrete pictures or geometric figures are displayed on the screen. The client has to memorize the position of the pictures. After a preset time, the pictures are turned face down and the client must find the correct picture. The module Memory for Words trains the ability to learn and memorize words. The client has to learn and memorize 1, 2, 3, up to 10 words. Afterwards, the client has to identify the memorized words among irrelevant words moving on a conveyor. 3 training modes can be used: simple words, compound words, or difficult words. The reading speed is adjustable in order to increase the demand on processing speed. It's worth noting that all the attention, memory, and executive function training modules are very rich in variety, and the complexity adapts automatically to the actual performance. Moreover, all modules are equipped with so-called parameter menus in order to customize each training to the patient's needs. Depending the particular training module and aim, you may find useful modifiers as distractors, rewards options, visual or spoken presentations, acquisition time limiters, and more. The REACOM modules are self-adaptive. They measure the current performance of the client during the course of therapy and automatically switches to the according level of difficulty. This forces neuroplasticity and warranties an optimal outcome. Due to the outstanding importance of well-functioning working memory, I would like to go into more details on this. Working memory disturbances occur in various psychiatric disorders and play a major role for general cognitive ability in everyday life and social integration. Indeed, working memory deficits have been associated with a long list of cognitive and mental health challenges. Some of these include schizophrenia, attention deficit hyperactivity disorder, and post-traumatic stress disorder, among many others. Working memory is an active and integrative stage in the human memory system. This is not simply a passive storage location for information on its way to long-term memory. Instead, working memory is an essential component in the processes of perception and encoding meaningful episodic events. This includes playing a critical role in attending to and analyzing incoming information. Deficits in working memory can lead to poor attendance to environmental information that is necessary to maintain a visual, spatial, auditory, or episodic representation in working memory. Moreover, working memory serves to integrate information into an episodic, holistic, and meaningful conscious representation upon. In turn, this is used to guide how we think and act according to current goals. Working memory deficits can present problems associated with focus, attention, integration of the multiple aspects of a stimulus, for example, auditory and visual components of a speaking person, maintaining goal directness over time, and avoiding mind wandering. REACOM's training module Working Memory supports both the storage and the manipulation components of working memory and increasingly involves selective attention and inhibitory processes at the same time. The functionality of the working memory provides a basis for many higher cognitive functions such as problem solving, speech comprehension, arithmetic, and intelligence achievements. How this training module works, I show you in the following short video.
The REACOM module Working Memory trains functions of the working memory. It is responsible for storing and manipulating information for short-term use. Working memory is the basis for many higher cognitive functions, such as problem solving, speech comprehension, calculations, and intelligence capacities. It is also responsible for storing what has been learned before. Training with this module is indicated for patients with neurological diseases such as stroke, traumatic brain injury, brain tumour mainly in the frontal lobe, and multiple sclerosis, as well as for patients with psychiatric, gerontopsychiatric and other diseases such as depression, schizophrenia, addiction diseases, and attention impairments in child and adulthood. Before starting the training module, it is possible to individualize the training parameters. Via the therapist menu, one can adjust the level of difficulty, duration of session, instructions, and help or stressors according to the patient's needs. It is possible to change these parameters at any time during the training. The task in this module is to learn and train strategies as well as to memorize, keep, and manipulate information. In this case, the stimuli are represented by a deck of cards. In the memorizing phase, playing cards will be presented one after another. Those cards then have to be recognized and selected from the bottom row of cards to be placed on a table. The first training level starts with 3 cards which have to be recognized. With rising difficulty, the cards themselves become more complicated. Then, the cards should be presented on the table in reverse order. During further training, the number of cards to be memorized and manipulated will rise to a maximum of 8. High-performance patients can optionally train further functions of working memory, such as resistance to interference. REACOM works auto-adaptively. The difficulty level will rise or fall depending on the patient's performance. The performance bar illustrates this development. With each change in level, the user will receive additional feedback. At the end of a training session, REACOM will create an evaluation graph. Training results will always be saved automatically, and the patient will continue from this stage when starting the next training session.
Here are the executive functions modules. The executive functions are higher order complex thinking processes. Executive functions include all the things that allow us to organize, make decisions, and solve problems. It also involves the way we monitor what's going on around us and adjust what we think and do in response to it. Signs for executive functions disorders are not being able to manage time well, difficulty meeting goals, difficulty determining the amount of time necessary to complete a task, difficulty in organizing and planning, trouble switching focus and shifting between activities, and difficulty prioritizing work or responsibilities. Therapists are provided by free modules with close to everyday life templates in order to train executive functions. One is included to strengthen logical reasoning, another one to practice shopping, and a third one to train a complex vacation planning. Supported by the therapist, the patient has to identify and consider solution-relevant information, develops precise approaches to the solution, plan and analyze the approach to the solution in parts, recognizes mistakes and steps that are not effective, correct errors, and develop alternative approaches to the solution. All therapy results are stored automatically in the client's database. The record allows for data-based treatment. The therapist can evaluate and print results in overview or in detail. An easy result view explains the progress to the client. The complex view allows the therapist to evaluate all details. In summary, in only 4 steps you are able to perform a therapy session. Do the REACOM screening, choose the therapy modules you would like to use or recommended by the screenings to treat specific core deficits. Choose the start level or start at level 1. REACOM adapts the level of difficulty automatically to the patient's performance. And finally, evaluate your patient's training results.
In this slide, EMDR therapy introduction, eye movement desensitization and reprocessing. The D and the R in EMDR represent those 2 words, desensitization and reprocessing. They essentially mean that the process of EMDR will desensitize the patient to the trauma's effect on their brain, and reprocessing in that it reduces the anxiety and trauma, and in the process returns the mind to a greater balance. So EMDR can resolve traumatic issues, and it should be noted that depending on how you count what are similar issues, there are between 3 and 5 alternate procedures that are available throughout the world. And in the research that most people have produced, it is relatively clear that EMDR may well be a superior approach for a number of reasons. The technique was developed in 1987 by Dr. Francine Shapiro, and the technique was found when she realized there was a connection between the trauma in the brain and the eye movement types that occur. She received the Sigmund Freud Award, among many others. EMDR is practiced all over the world and has become probably the most popular of these trauma-reducing approaches. In EMDR therapy introduction, Dr. Shapiro, while walking in Los Gatos Park in California, had experienced the trauma in her own life, and at that time felt that there were weird eye movements being made, and that this was something that she would corroborate with her colleagues upon return from the walk. She noted that eye movements occurred while thinking of something disturbing, and therefore led to that third section of the slide involving manipulating eye movements that may influence the trauma in the brain, since the trauma appears to be producing the eye movement. In this slide, initial training, therapists affected eye movements in order to affect the trauma within the brain. Initially, by moving their arm in front of the patients from left to right, but only in that horizontal dimension, not specifically from left to right only, but left to right and right to left. So that's an alternating back and forth along a horizontal dimension. And this was done about perhaps 50 to 100 times every cycle, and there are many cycles that would be required during an EMDR resolution session, and it was demanding upon the arms of those therapists. The patient must also develop a picture of the traumatic event, and so that the brain has something specific to focus upon. Also, there is a requirement for the patient to identify feelings associated with that picture so that the brain can focus on that as well. In this slide, first session, while the picture was retained in the mind's eye, the patient was asked to identify feelings and where they were felt on their body. It is worth pointing out that it can be anywhere in the body, including the appendages of arms and legs, and within the head is also popular. However, I have found over many years that the location is ordinarily from the waist up to the throat. And each location identifies not just an area of greater intensity moving from the waist up to the throat, but also correlates with the SUD score. In the next box that we have, lastly, the patient was asked what the SUD score of the pictures and feelings represented. SUD means subjective unit of disturbance and is on a scale from 0, which is nothing at all, to 10, which is the worst possible level of trauma that one can choose. The patient then focused only on the picture and feelings and nothing else. This is extraordinarily important because if the patient becomes distracted and begins to think of other things, they will disrupt the value of that particular cycle. And this is the most important task that a new patient has, to be able to focus clearly without distraction. In the left part of this slide, we see patients who are new to the experience, usually getting distracted by other associations to the picture and feelings. That's quite typical, and it takes a little bit of practice on their part in order to be able to focus on just the picture and the feelings and not other associated ideas. The role of the therapist's arm in the early days changed over time to other interrupters. The interrupters are those stimuli, bilateral, which involve moving lights left to right, such as you might see on a theater marquee, especially in the old days, a buzzing device, one in each hand, and beeping sounds that occur alternatingly from one earplug to another. So these interrupters allow the brain to be distracted to the point where it can focus only on the picture and feelings and thereby reduce their traumatic level. In the slide, how it works, it is noted that the score will drop from some higher level that is chosen by the patient. As the brain adjusts to the lower level of anxiety, the score drops to 0, and then, as some people say, the magic occurs. However, the magic is not really magic, it is science. The traumatic memory then moves from short-term memory, which is where the trauma does its work in disrupting the patient's life, to long-term memory, which allows the patient to be free of intrusions. As long as it is stored in LTM, it is much less likely to provide the patient with a negative experience. In the slide PTSD and memory storage, there are those who believe the brain should have stored it in LTM immediately, and I do not have that opinion. The panic reaction of PTSD is what occurs as the brain meets the initial trauma, and it happens to store the memory in STM. The question for many is, why go there? Why not go directly to LTM? And I think Mother Nature does that as a way of constantly reminding the patient that this PTSD issue and trauma representation is to remind the patient at all times that this is bothering you and must be dealt with. In the slide closed loop behavior, STM storage allows panic attacks as a reminder, as I just mentioned. The brain then does what it can to ameliorate the reaction, and that is the closed loop behavior, which requires the brain to respond to the physiological changes that occur. And that is indicated by the increase in anxiety, the short-term breaths, the increased heart rate, with the corresponding need to move, stand up, go away, or go outside, so that they can try to escape those symptoms. By trying to reduce or remove the symptoms, the patient often tries something like the following of, quote, "This isn't happening now. I'll slow down my breathing and my heart rate will slow and then I'll be relaxed." This action is called a closed loop behavior because it is closed in that it leads to temporary resolution and calm, but it is not long-term by definition, and so the patient will just be buying time. In EMDR ruleouts, it is useful to mention these ruleouts, of course, because these present issues with body functions that would be worsened if EMDR were used. One set of ruleouts includes seizures or severe visual problems so that patients cannot use the lights because they might prompt seizures. So in these cases, there are two solutions. One is to not use visual interrupters, since I mentioned that there are two other types, and those are the vibrators in the hands and the auditory beeps that occur alternatingly in both ears. Besides that, if there were seizures or severe visual problems, they would not necessarily rule out using those interrupters in the EMDR procedure, but they would require us to check with the physician involved to give us the idea that we could go ahead or not. In the slide, the 8 steps, these are procedures that were indicated in one of her major texts. Dr. Shapiro pointed out that we need to obtain a client history, much as we do with any medical or psychiatric intake. List the events that were or are problematic in causing trauma and their triggers. Preparation. Because there is fear that is part and parcel of eliciting the traumatic event for cycling out of that error that they have in their memory, we need to encourage the patient to be mindful of the process and not be afraid of the fear, as she indicates. 3, the assessment. This is where the patient begins to ascertain a specific memory and in a specific manner. So it is the what, when, and where, and what negative beliefs they have about themselves as a result of having experienced this trauma. Number 4 is desensitization, the process explained earlier with repeating the picture, feelings, and changing SUDs. The repetition occurs with each cycle of many cycles, depending on how long it takes the patient to go from some higher SUD number to 0 or 1, so it moves from STM to LTM. In that process, by definition, the patient is becoming desensitized, and that is less overly responsive to that initial trauma in the mind. In the next slide, also the 8 steps. Number 5 is the installation, to connect the negative percepts of number 3 above to the positive aspects now. That is, seeing how what was a problem has been turned into a positive experience. Number 6 is to body scan. Check for any remaining physiological sensations that are left, like numbness, tingling, or heat rushes, etc. Number 7 is closure, an attempt to deal with feelings and sensations left by using the process of guided imagery, and there are a number of choices left for the therapist to employ. I'll use relaxation approaches as a way of aiding this process. Number 8, and the last of the steps, is reevaluation, to be sure there are no issues related to the prior event's resolution. This is probably best done not in the initial session, the one that resulted in an apparent resolution, but rather in subsequent session or sessions, which may even require redoing the entire series of cycles related to that trauma. In the next slide, not just for trauma, it's an important point to be made. Since most people think EMDR is only for past events and for trauma reduction, that is, you're already upset by something that occurred in your life and you want to get rid of that. And that, of course, makes great common sense, and that's the vast majority of the work that an EMDR therapist does. So, in explaining how this is done in a different way, I'll revert to what we mentioned in an earlier slide of past and future events. The future events part recurs when we talk about the future event that a patient knows is coming that will be quite traumatic for them, and for us to treat that as though it had already occurred in the past, but rather to reduce those traumatic or anxiety or angry confrontations that might occur ahead of time, so that when they experience that future event, they are better prepared to deal with it on an emotional basis. In an example, I had a patient who was seeking a very significant raise from his boss. So we set the picture in the future of the exact office which the patient knew, and his boss, of course, which he knew well, and followed with his feelings, a picture, and an SUD score. Other future events, such as confrontations, could also be ameliorated by EMDR, and so it is a much more flexible procedure than one would imagine on first blush. In this slide, a woman patient's issue the gun. This is a middle-aged woman who was about 11 years old, her sister about 9, and her brother 3, when she explained her father, who was a policeman, placed his gun on top of the refrigerator and severely warned them to never touch it or else. She was incensed and actually even enraged by his inappropriateness, and was still enraged 40 years later. We determined where she felt these feelings, in her chest and stomach, and the SUD score was 10. After the first cycle, she still had a 10 and was enraged, and she noted the score was a 10 with, "It's still a 10," as though there was pride in what had happened. After a few cycles, one of them led to a softer response on her part, and that was when the score reached about a 5 or 6 level. She noted, in her own words, "My parents are good. They wouldn't do this to hurt us." Then, "I really do understand. I have a teenage son, and it can be difficult." Later yet, she was getting tired. As the score dropped to 1, she then begged off another cycle because she felt so tired, and as part of the procedure, I needed to encourage her to go at least one more time because we wanted it to drop to a legitimate 0 and be sure that this trauma would move from STM to LTM. About 25 minutes later, during this one session from the start, she wanted to sleep. This is obvious and clear evidence what EMDR does to resolve issues. I should note what you have already seen, that as the score drops, so does the rage, the anger, the fear, whatever is involved as feelings, that becomes more and more diminished. And you can see EMDR at work as the patient becomes more relaxed, and actually, in this case, to the point where they just want to fall asleep, because the brain is essentially communicating to them, "We're done with this issue. Let us move on." This next story of severe pain reduction involved a patient whom I had seen years earlier, and at the time he was in his mid-40s, was when a serious car incident occurred with him on the front passenger seat. He suffered a concussion and coma in which he recognized none of his immediate relatives. The number of sequelae was great, affecting every part of his body. There was damage to his head, cervical spine, thoracic spine, shoulders, hips, leg joints, and feet. He was placed on multiple opiate-based medications, which helped only a little. He had 2 to 3 physicians, surgeons, neurologists, and attended physical therapy along with cognitive therapy. As I mentioned, I had seen him many years earlier, and when he called, I decided that the only thing I could do was to give EMDR a try to at least make him feel better, even if the pain level could not be altered. In this next slide, I needed to visit him at home because he could not travel outside his home. He looked old and tired. He answered a phone call from a client, and by the way, he was a high-level insurance agent and was speaking for about 5 minutes to obtain information for an insurance policy change. When he hung up, he said, "I don't remember anything from that call." I found he could only function adequately for about 5 to 10 minutes a day, which was shocking. It was then that I began with EMDR, and I employed the beeps for 15 minutes and then stopped asking how it worked. He said nothing. I said, "You mean it didn't help?" He said, "No, there's no pain." It was hard to believe EMDR did this, and it led to 4 years of continued EMDR for anything that arose. Within a few weeks, he moved from 10 to 15 minutes a day working to 2.5 hours per day, a very dramatic improvement. In the next slide, beyond severe pain, his cognitive therapist, who had this singular task of helping him with cognitive problems to challenge his mind and thereby improve it. We did EMDR prior to his weekly cognitive session to see whether or not the EMDR would lead to a different response to the 2 word problems that he was unable to solve for over a year. After the EMDR session, he solved both and said further, "I told her there were 2 solutions to one of the problems." I might add here that this is a bit similar to using EMDR to resolve issues that interfere with cognitive functioning, i.e. in Reacom therapy sessions. His relationship with his wife and son improved, and though angry about his situation by saying, "I'll never get better, it'll only get worse," he now had flashes of hope. Explanatory metaphors. I explained to patients that as the SUD score reaches 1 or 0, the trauma moves from STM to LTM. Now, that may not be a precise neurological explanation of what happens, but it is cognitive and practical so that they can get an idea when it leaves their mind and that it's a good thing. On the second part of that slide, you see patients are not always sure whether it has left. So I asked them, "Does it seem like something left your mind? Do you feel relieved as though it is gone and you won't need to deal with it again?" But regardless of how accurate this initial assessment is, the true test of efficacy of this EMDR session is post-session. In other words, does the real-world experience corroborate the assumption that they're better? In this last slide, for me, research, there's a review of the neurobiological studies of EMDR, as well as the theoretically driven speculative models. Bergman, in 2010, wrote a book titled EMDR's Neurobiological Mechanisms of Action, a survey of 20 years of searching. There's also the Journal of EMDR Practice and Research, which I had used to be able to determine whether or not EMDR's ability to deal with pain was legitimate and possible. In this next slide, a distillation of 5 decades of experience, I might point out the obvious that this banner title is proof that I am an official old bag. My book, The Match, to the left has a very long subtitle and required, as I mentioned earlier, about 10.5 years for me to publish. And in there, in the next section of the paragraph, an inspirational resource for those working in the field, combining a psychological perspective with a hands-on pragmatic approach, is a quote from my analyst at Columbia in the 1960s. I would add that it contains Reacom and EMDR therapy to change brain behavior, including chemical dependence and other issues. I suggest you purchase this from Amazon to understand more and to prepare for our webinar, whether you plan to attend participation or not.
Thank you, Al, for the insight into your therapeutic work. Here's our conclusion. Impaired cognitive capabilities are regularly found in several domains, that is, attention, memory, and learning, and executive functions. Cognitive impairment is an important factor contributing to poorer functional outcome in major psychiatric disorders. Computerized cognitive remediation with Reacom has been shown to be effective in improving both cognition and functioning. EMDR therapy facilitates the accessing and processing of traumatic memories and other adverse life experience to bring these to an adaptive resolution. And this is our take-home message. Elimination of emotional distress and improving cognition leads to improved patient outcomes.